Good morning, good afternoon, and good evening to everyone who's joined today. Thank you so much for joining us today at this seminar, webinar rather, on getting on the same page, the concept and assessment of health system strengthening. The seminar has been organized by the Rebuild for Resilience Research Program Consortium, but it has a number of other organizations represented on the panel. Today, my name is Kabir Sheikh, and I work as a policy advisor at the Alliance for Health Policy and Systems Research, which is a partnership based at the World Health Organization headquarters. And I'll be chairing the webinar today. The objective today is to explore the latest thinking on both the conceptualization of health system strengthening, but also on the prospects for adopting shared tools and approaches for its assessment. So it's a big ask, it's a complex area, a complex question, a complex set of questions, but we are hoping to we have some excellent speakers, and I'm sure we have lots of people in the audience who can really help us think this through. And we're hoping to make some headway in terms of understanding whether we can get on the same page, and if so, how will we get on the same page? We've also got lots of time for, we have 90 minutes today, so not a huge amount of time, but we have, I think, enough time for a solid question and answer session towards the end. And we want to hear and engage the audience as much as possible. So we will go without a break today for 90 minutes. We'll start with a brief introduction by myself, and then each of the 5 speakers will present in turn. And we'll then invite questions and ask the panelists to respond to questions, and then we'll sum up with final reflections towards the end. So at the end of that, we hope to get some directions and answers for this set of questions on health system strengthening, conceptualization, and evaluation. The session is expected to feed into work by researchers at both national and international levels, but also crucially into interagency work on improving international support to evidence-based health system strengthening. And a particular focus will be given to the findings of the 2019 and 2021 reports, which are named Evidence Review of What Works for Health System Strengthening, Where and When. And these were commissioned by the UK FCDO from the Rebuild for Resilience and Resist Research Consortium. Can I have the next slide, please? So these are your speakers for today. We have Professor Sophie Witter, who's the Rebuild for Resilience Research Co-Director. We have Jo Keatinge, who's Health Advisor for Universal Health Coverage and Health System Strengthening at the FCDO. We have Dr. Olga Bornemisza, who's Senior Advisor for Health System Strengthening at the Global Fund in Geneva. Dr. Sushil Baral is the Director of HERD International in Nepal. And Dr. Natasha is a consultant with ITAD UK. I will introduce them more fully before each presentation. But here's their faces so that you know who's going to be speaking. Next, please. And that's me. That's your chair for the day. And let's get started now without further ado, exploring the latest thinking on conceptualizing and evaluating health system strengthening. Next slide, please. So let me just get us started on some of the big picture questions that come to mind, and also to ask some broad questions that might be helpful for the panel to consider, but also for the audience when we conceptualize health system strengthening. So as we think about what health system strengthening means, the first question, of course, is whether we actually share how we conceptualize health systems first. There are a set of reasonably consistent definitions of health systems. However, there is also an active debate around whether the broad definitions of health systems reflect a more sort of socially embedded character. Do they also include creating the conditions for better health, going beyond the actual health systems building blocks when thinking about health determinants? There's also a very active debate happening around whole of society and whole of government when we consider health systems responses and health system strengthening. So that, I imagine, is one of the first questions that anybody thinking about conceptualizing health system strengthening would ask themselves, whether we should be focused more on the building blocks, the conventional architecture of health systems, or whether we should be looking beyond. There is, of course, also the question on whether we should be looking at strengthening mainly in terms of the functions of health systems and its outcomes. The conventional outcomes that are used, for example, for universal health coverage are access, coverage, equity, quality, and security. Or whether actually for health system strengthening, it might be more useful to look at a set of attributes of health systems which reflect that they have been strengthened. So there are concepts like resilience, which have come to vogue in the last 15 years or so. Responsiveness has been around for a long time. We've now started doing some work here at the Alliance for Health Policy and Systems Research on learning health systems, and that's a theme that's emerging quite a lot in the development literature and the development thinking around learning health systems. So these all represent particular characteristics, broad characteristics of health systems, which could be seen to reflect a transition from a weak health system to a strong health system. And in that sense, might also be more useful lenses. And associated with that is the question around whether assessing strengthening is the same as assessing performance. And I think most of us would agree that it isn't, but is this an overlapping set of considerations, or is it completely distinct? Next, please. So in relation to this, again, this question drawing from the question on whether health systems, what exactly health system strengthening is this question of time and whether it has been considered adequately as a variable in health system strengthening. When we are looking to strengthen health systems, do we see this as a project, or do we see it as a long-term intervention? Once the intervention ceases, does strengthening cease? Or is it that health systems will be in a position where they are able to continue to strengthen themselves? And I think that's actually at the crux of a lot of the questions that the panelists will be answering today. And one, can I have another click, please, Sophie? And one question, of course, that does present itself is that now we are seeing with the COVID epidemic that systems that haven't necessarily learned from previous experiences are not as successful in dealing with the COVID epidemic. And unfortunately, the sort of wild truth of that is that it's actually too late to strengthen the health system now, but we often remember health system strengthening only when it's too late. So in that context, it's more important to consider that health system strengthening has to be for the future, learning both from the past and the present. And systems that don't learn from that history are, in a sense, condemned to repeat it because there is they continue to make the same mistakes. So here's a quick overview of the learning health systems concept that we hope might help you think through some of those issues, and really helps to conceptualize health systems not only in terms, health system strengthening, not only in terms of the improvement of performance of functions, but also in terms of the system's future ability to adapt to change and also to engineer and generate change. And ultimately to contribute to greater self-reliance of those health systems and ability to create the knowledge, the learning that it needs for itself to sustain performance at a high level over a period of time. Next, please. And finally, when we come to this issue around assessing health system strengthening, which is also what the panelists are going to address, I think it'll be important to think about four key questions. First is, are we clear on what constitutes a strong health system and a weak health system? So what is the actual change that is expected to occur when a weak system transitions to a strong system? Is there a space for different types of methodologies, different types of approaches, different types of knowledge in assessing the different types of change that might occur? The time element that I raised earlier, is strengthening really for now or for the future? And are there any trade-offs involved in whether we strengthen for now or we strengthen for the future? And also, how does that affect how we assess the health system strengthening? And finally, and I think this is something that we actually might be able to address through even in these 90 minutes, is whether a common evaluation framework for such a subject as complex as health system strengthening should be a broad one, should it be an encompassing framework? Or should it be one where we try to be parsimonious and really try to find common ground? Next, please. So I'm sure that our panelists will have the answers to many of these questions, and I hope that's helped to set up the panel. Let me start first with the Professor Sophie Witter, and I'm sure that she'll have many of the answers to those questions. Sophie, would you mind unmuting yourself and also showing yourself on video? Professor Sophie Witter is Professor of International Health Financing and Health Systems Research at Queen Margaret University, Edinburgh, and co-director of the Rebuild for Resilience Consortium. She's worked in global health for more than 30 years, including program implementation and management at Save the Children, and as a researcher and evaluator at the Universities of York, Aberdeen, and QNU, Edinburgh. Her work in recent years has focused on health policy, finance, and system in low and middle income countries, including fragile and conflict-affected settings. Over to you, Sophie, for your presentation on health system strengthening in LMICs, reflections on challenges and evidence.
Thank you very much. Thank you, Kabir. And as usual, you've set out all the major questions at the start, and very ambitious agenda for us. So just to say a word quickly about Rebuild for Resilience. So, well, Rebuild as a consortium started in 2011 and was focused on health system reconstruction post-conflict. And now in our second incarnation, we are focusing, again with FCDO funding, on resilience capacities in fragile and shock-prone settings, and working in 4 partner countries and with UK partners. So Sushil, who'll be speaking later, is one of our research partners. So delighted to be on this panel today. And just to take the story back a little bit, so our exploration into this evidence base for health system strengthening dates back to 2018, when DFID asked Resist and Rebuild to do an evidence review on what works for health system strengthening. And the focus, quite reasonably, was on understanding what works where. And that was meant to feed into a DFID health system strengthening position paper, which I think Jo is going to update us on later in the panel. And one of the things, and Natasha, who's on the panel, was also part of this review. But one of the things that arose immediately as a kind of surprise in a way was how few existing reviews there were on health system strengthening. And I think that's linked, or our view was that's linked to the lack of consensus around really what health system strengthening is, and to some extent that connects with its history as a concept. But also a lot of the studies that we found were looking at specific issues, but not with a sort of system strengthening framework. So we think there's work to be done on the kind of evaluation frameworks, and Natasha is going to pick up on that topic in her presentation. So the health system, as Kabir has already introduced, the most common definition is the WHO one. The health system consists of all organizations, people, and action whose primary intent is to promote, restore, or maintain health. And that's a very broad one, and obviously can encompass a multitude of systems, so not just the public system, but pluralistic health systems. But the kind of core model, which is most typically used, and indeed we used it also for our evidence review, has these 6 blocks as their center, and does tend to focus its gaze on the public system. There's there are some intermediate indicators, so if you like, kind of outputs around access, coverage, quality, and safety, and then a quite well, I think, appreciated set of goals for the health system, which focus not just on health itself, but also its distribution, which is very important. So the equity issues, responsiveness, which brings in some of the more intangible elements, which we all think are really important around a health system, the way it treats people, not just in health terms, but more sort of people-centeredness, for example, managing financial risks and improved efficiency. So I'm not going to be focusing on the right side of this framework, because I think it's there's less controversy around it. There has been more debate around the kind of building blocks, not least the kind of hierarchy within them, but also the extent to which elements like community is not present. And so quite a lot of thinking has been done around that. But the health system model as such is quite well accepted. So that should mean that health system strengthening is fairly straightforward, shouldn't it? It should mean that it's really just about improving those functions. But when you look at the health system strengthening as a concept, there's actually no clear consensus on how it's defined or measured. And in many ways that relates to its history, which a lot of the writing around health system strengthening doesn't originate with people who are working kind of within a broad system framework, but more came from a analysis of interventions and investments by external actors and global health initiatives, many of which were focusing on specific disease programs, and were then looking to understand how their investments or interventions were affecting that wider system, the kind of scaffolding which supports all of those disease programs. So just to start with the WHO definition, it's very broad. So it's any array of initiatives that improves one or more functions of the health system. But then there's a set of thinkers who started to try and define in more, because in a way that's good, but it doesn't exclude very much, trying to define more explicitly where the boundaries might be. And so, for example, Adam and de Savigny were highlighting that changes at the organizational level alone, I mean, an organizational level as such isn't really there in the framework for WHO because it is a system framework, but that there needed to be a kind of higher level of effect for something to be considered a health system strengthening intervention. And then there's a very important paper in 2013 by Grace Chia and other co-authors making the distinction between kind of, if you like, gap filling and inputs to a system versus something that really addresses the functioning of the system per se. And so for our evidence review, we tried to build on that a bit and kind of put some of these definitions together and added a little bit to come up with 4 dimensions, which seem to us to be important when we think about health system strengthening. So one is around scope, saying that there should be effects which cut across building blocks in practice, even if not in design. And actually what we felt when we reviewed the evidence was there are very few interventions in one area of a system which don't have knock-on effects. So in a sense that fulfills itself quite easily. Also recognizing, yes, it is important to be going beyond one disease area. But secondly, a set of criteria around scale, so not just very small scale pilots, but there needs to be some broader reach, and ideally across more than one level of the system as well. So having some kind of, if you like, vertical interconnections between referral levels, between community and facilities, for example, or between primary and referral facilities. And then, yes, the effect side is also important. So there should be some impacts on outcomes, equity, risk protection, responsiveness, so the health system goals. But recognizing that those don't always occur straight away. So we do, as Kabir said, we really need to be mindful of that issue of time and understanding how change can take time and tracking it appropriately so that we detect those significant changes. And then finally, this element of sustainability. So clearly a change that has no longer term effects is not really reforming a system, it's simply making a short-term investment. So there has to be some element of systemic blockage that's being addressed. So this was a proposal, but just to note that there isn't a consensus and different agencies have different definitions and some of those are still under development. So this is still a kind of moving field. So why does it matter? You know, is this just sort of academic nitpicking? But we think it does matter because, well, firstly, health system strengthening is a big and a growing area of investment. But actually tracking that investment is in itself quite hard if we can't be sure. For example, if we look at the pie chart on the right here, you've got development aid for health, assistance for health, which is classified as being health system strengthening, but you'll see that quite a lot of it is linked to different disease programs and different programmatic areas. And it's quite hard to know, you know, how within those, how the money is being spent and whether it's appropriately classified as system strengthening. So just understanding changing investment is quite hard, but also making decisions about what's working and how we improve design. It means it's important to understand what are the criteria and what are the qualities that we're looking to track. When it comes to priority setting within health system strengthening, it would also help to have a clear understanding of how we measure success. So when we look at allocations internally, we can make some judgment about whether they're appropriate. So if you look, for example, at this figure you've got, which is using the OECD database, you can see that within the system-wide health system strengthening, the biggest block of investment is on infrastructure for service delivery. Whereas, for example, within the infectious disease program strengthening, there's much bigger investment in supply chain and commodities. And so, and similarly for other areas. So we're seeing different patterns, but it's actually very hard to know if those patterns represent good priority setting and allocation, unless we have better outcome measures of what is a strong system and how is it changing over time. So this brings us on to frameworks for design and assessment. And again, Natasha is going to pick up on some of these, but just to say from our evidence review that what we noted is that many programs have quite narrowly focused theories of change, and that is what they track. So even though they're, let's say, a health worker training program, for example, is very likely to be having spillover effects into all sorts of other areas, of course, service delivery, but maybe also information systems and drug supply and so on. Those will not be tracked. Typically, the evaluators or assessors are going to look very closely at their area. So they're actually kind of siloing what may well be a system strengthening intervention. Also, just to note that the overall literature does have its own biases based largely on the kind of funding patterns. So interventions which are seen as somehow new tend to get much more focus, even though some of the core system functions around budgeting, performance management, supervision, things like that, they're kind of boring old hat, but they are the workhorses of the system. They get much less research attention. So the literature's got a kind of skewing in it towards simpler, short-term, more externally financed projects. And also areas that are seen as policy interesting, I think. So we see a sort of inverse relationship between the amount of money that is spent on areas like commodities and supply chain management versus the research effort, which is much more focused on areas such as human resources and health financing and governance. So what that means is there's gaps in the evidence, there's some evidence of bias, but also where there's no evidence, it doesn't mean that intervention isn't working. So for evidence summaries, that's quite challenging. So what kind of indicators should we be looking for monitoring health system strengthening? So this is from the 2010 report by WHO. It's the sort of most authoritative sort of set of health system strengthening indicators. It's organized according to the sort of flow of inputs and outputs, outcomes and impact. And there are 17 core indicators which follow the kind of system blocks. But when you look at them, they are relatively basic. They do link better to existing routine information systems, but they don't really tell you very much about functioning. So, for example, the health worker indicators are things like density and numbers and training numbers. But actually what health workers are doing and how well they're performing is not really tracked. And this is a common problem, and it does link to measurability, but it leaves a big black hole in the middle. And so in the evidence synthesis, we started just trying to think about what we've called the health system process goals. So recognizing that, yes, we do need to track inputs, but we're also interested in the kind of mechanisms of change. So what is the kind of, the sort of change logic that different projects are introducing? And just as a kind of side note, we did a literature review later in that year that looked for DFID at the donor investments in health system strengthening, and that inductively produced 23 mechanisms of change. And perhaps not surprisingly, training and new systems were some of the most commonly cited ones. Whereas changing relationships within an organization and between organizations, which might well be a very influential area, was the least commonly cited in the programs. So this central box of process goals is not at all advanced thinking, but it was really just trying to think around the question of what is a strong health system, what does it look like, and what do we want to see. So this links, I think, to Kabir's point about attributes. Really, many of these are attributes that they're still really important to understand when you're designing and measuring change, how well you're reaching some of these facets. And so I'm not going to go through them because I'm probably running over time, but just to say that we think a lot more work could be done around understanding these. And some blocks have started thinking along these lines. So for example, the health financing team at WHO has just this year produced a whole set of guides around health financing progress matrices, which have tried to say, what is a strong health financing system? What does it look like? How do we know if it's happening? How do we measure it? And in a way, that makes a huge amount of sense. But can we do that for a whole health system? So that's the challenge. And I'd be really interested to hear people's thoughts about that. So I'm not going today into the actual evidence itself, because we're more just thinking around some of these methodological issues, but just to highlight that we did address, we did bring out the areas where we thought there was stronger evidence and supported the overall importance of health system strengthening and also the opportunity costs of not doing, but highlighting the importance of understanding the kind of contextualization of interventions. So issues around also context, software and history. And also making the important point that health system strengthening isn't going to be appropriate in all settings. So particularly if we think about emergency settings, for example, donors or others intervening to prevent collapse can be a very important legitimate intervention. So we're not necessarily always going to be in a position to be thinking about strengthening systems. Sometimes there will be another goal which is important. But we try to bring out some of the factors across the different studies which contribute to success in health system strengthening. Again, I'm not going to go through all of those, but some of them, came out very strongly. For example, community involvement, obviously quality of implementation, but also this importance of kind of iterative learning and adaptation. And so I just wanted to highlight, while we're on that theme, the link between the learning health system, which Kabir was talking about earlier, and health system strengthening, because we think they are closely connected. And obviously a learning health system is not just about data and evidence as it's normally understood, but also very much about recognizing the importance of experiential learning, of participatory and learning through dialogue, and the importance of and the value of investing in the kind of systems that support that institutionalize it, and also, of course, putting resources into those learning functions. So I think quite soon the Alliance is going to be launching a flagship report on learning health systems, which I had the honour to contribute a background paper to, but just to say, sort of watch that space, because that's going to be a very important agenda item. And I think this learning aspect is critical to health system strengthening. So just to finish then, what are the priorities now? I think one of them is reaching agreement on what constitutes health system strengthening. And I think it's really important to start with a bit more of a bottom-up organic approach. So recognizing that some of that history has been a bit top-down and externalized. And I'm hoping that I know that Sushil will be talking to that agenda item. But also, how do we bring in more strongly these public, private, informal sectors and the role of communities and community health systems? So I think that's one priority that I would like to highlight. The second one is agreeing on, or potentially agreeing on what a strong system looks like and what are the kind of indicators for it and how can we track those over time. And ideally that would be done in a more routine way and linked to periodic and routine information systems, because there is an issue around the cost effectiveness of methods for doing very intensive one-off external evaluations. And so number 4, and again, maybe Natasha will come back to this, is just thinking a bit about some of the methods for doing that and whether we can use modeling from those intermediate system processes to outcomes or look at the connections between them. And focusing also on building evidence in more neglected contexts where conditions might be different. And of course, coming with a rebuild hat, I'm very interested in particularly thinking of the fragile and shock-prone settings, which have been relatively neglected in terms of health system strengthening. So thank you very much. I hope I haven't gone too over time. I haven't got a watch, so I can't see. Back to you, Kabir.
Thank you, Sophie. I think it was important for you to talk through, and you didn't go over time, so thank you very much for that. But we do need to crack on because we have a lot of other speakers and we want to keep enough time for questions. So I won't try and do a detailed summarization, but thank you. I mean, I think you really highlighted for us some of the important questions, really. So it's like you gave some answers, but it also really gives rise to a lot more questions, your review, as a review should. I think this point around divergent goals from interventions and how that creates different expectations from what health system strengthening is. And also this issue of the multiple functions, and that we have this sort of really long laundry list of health system strengthening indicators. But how are we really going to move from there to a sort of common ground? And should we really be striving for more parsimony in how we identify this sort of thing that is health system strengthening? I think maybe that's something that the panelists can continue to think through in their presentations, and we can focus on a little bit in the discussion as well. But thanks again for that really masterful review, and encourage everybody to read the report, which is on the Rebuild website as well. Sushil Baral is a principal investigator for HERD's Rebuild for Resilience team. He's a public health researcher with nearly 3 decades of experience in health systems, health policy and planning, embedded implementation research, and scale-up of evidence-based practice. As a former DFID health advisor, he's contributed to the design and execution of DFID support of the Nepal health sector. Delighted to have Sushil with us, talking about health system strengthening at the national and subnational level. Over to you, Sushil.
Thank you, Kabir. Let me start, welcome everyone to my presentation. Let me start with the key perceptions that I often hear at the national and subnational level. And largely, equitable access to quality health services has been mentioned across the policy documents of the government. And the government colleagues, they tend to think pretty much that health systems strengthening policy goal has been addressed. And contrary to that, the many civil society organizations or other people outside the government think that still the policy has not yet implemented and not benefiting the poor, and it ignores the largely different attributes of the health system strengthening. Likewise, when we talk to the people who are actually receiving the care, they think that the accessing care is very, very difficult for them when they needed it, and it's very expensive and it's not patient-centered. Whereas we also hear from the development partners that it is unclear, the ways of addressing health system strengthening policy goals in practice, and there is no more need. There are ways of addressing these various concerns, but I wanted to highlight that this takes a varying understanding about the definition which Sophie spoke earlier, and its intervention and measurement evaluation measures. So it's hard to gain consensus at the national level what the health system strengthening policy goals should be and how that need to be measured and tackled. And there is widespread feeling that health system is public sector. Public sector is largely or only sometimes considered as a health sector, health systems. However, it leaves so many aspects. For example, the households, the private financing and the private care provisions. It also leaves out the huge amount of health workers outside the government. So that's why I urge that health systems are plural, but it's often defined in otherwise. And when we talk about the patient-centeredness, largely government provides free basic care of certain component. There is a package, and they tend to think largely that this is a patient-centeredness. But there are other wider aspects of the patient-centeredness, which should not be defined as a biomedical approach only. There is only societal approach. The holistic view need to be considered. And largely, when we talk about the evaluation of measuring our health system policy goals or health system strengthening goals, largely we take national averages, and there's lack of desegregation of the data, which some people think complex and not needed. That further leaves the people who are left behind. There are ways of doing it. There are approaches, there are ways of embedding health system strengthening concepts and policy goals into the national and subnational system. And I urge that there are key asks in this process. Particularly, we need to understand what are our policy goals for HSS, which is important to be discussed at a larger scale, wider than the government stakeholders, and bringing the society into account. And the second question is important to discuss is how can the health system strengthening policy goals can be measured. As we heard from Sophie, I mean, there are ways of doing it, and we'll be hearing more from other speakers about how do we measure in country context. However, the big question here to me is what can be done differently within the available resources, within the existing system, what might be improved, and how the effectiveness could be performed to the next level in terms of addressing the policy goal. That is feasible. If we look at this policy development cycle, we can ask several questions, and we can use appropriate tools and mechanisms in order to answer this question, so we can embed the HSS concept and approaches while developing the policy process. Not only the developing, but also looking at the evaluation of the policy framework, as well as looking at the result framework. Do we have enough data to do this at this point of time at the national and subnational level? Many say yes, and many say no, or somewhere in the middle. I would start saying that, looking at my experience working with national government and subnational government, there are ample opportunities and several platforms that we can use. We can link these various data points in order to generate a meaningful evidence that can be used appropriately. But it's very important that we require a system thinking when we start connecting these various data sources in terms of understanding the health system strengthening approaches at the local level. There are ways, I mean, we have seen that simple evaluation measures, which basically looks at what works, what doesn't work for whom and how, that need to be explored. And that need to be tailored to the local context, as one side does not fit for all. I think this is very important to realize that. And then we can move to the gradual, I mean, a longer term centralized database, which then can be used in order to assess the effectiveness of health systems strengthening policy goal, which again requires a holistic system thinking, which somehow we are missing, but it's coming up in many ways, but that need to be connected. And the last point here, I see the raising awareness. We often disseminate our findings at the national level, but we tend to forget the subnational dissemination of taking the subnational data and having exercise, discussing with the subnational stakeholders what difference could be made and how the policy goal of health system strengthening can be achieved in this context. Obviously, there are a number of different tools which we require taking into consideration. For example, leadership and governance in health system strengthening is paramount, information systems, but finance is one of the key tools, and that basically acts as an execution of the policy of the national policy at the subnational level as well. So we need to ask certain questions while we think about finance as a policy execution tool. Are there harmonized ways of allocating resources across the national and subnational level? It needs to take into account the population consideration and health needs of the population, as well as the geographical hardness and the burden of disease. And how these resources are being tracked. Do we have a routine mechanism to track these systems, whether they are delivered in a meaningful way and really contributing towards achieving the health system's policy goal? Are they progressive and inclusive? Yeah, we do have some examples. Nepal is on the way of finalizing its health financing framework, which basically looks at the policy in priority in total resource allocation. We are in a federal system. We have 3 tiers of government in Nepal, and I mean, it's pretty much a devolved structure here. So we need time series data from subnational government that can be built in terms of tracking the health system budget marker across the provinces, across the local government. And not to be forgotten that execution of the policy goes a longer term up to the local level. And the annual work plan and budget process is really, really important to take into consideration. How do we plan our health system goals and services at the local level? Also, it's important that often this community segment, the community engagement part is left out. It may not be deliberate, but there are bureaucratic or systematic issues which does not really always allows for the greater engagement of the community, a democratic process of engaging them in terms of defining their own needs, which then links to the wider health system strengthening policy goal, it has to be a priority. There are a lot of actors supporting the health sector strengthening, and one of the main actors we also see here is the development partners. And we need to think more seriously how the aid can be translated into HSS, into action, rather than just aid. Given the fact that government expenditure GDP on health is very low, which has been complemented by development partners, as well as the large private sector out there. However, still our health system is largely driven by disease central and vertical processes. When my urge is vertical programs, it does not mean that they do not address the health system strengthening policy goal. They do, but I think it may take a long time if we continue to have a focus. So I'm urging here, there has to be a greater balance in terms of how, in a way, the focus on disease-centric program, as well as the system strengthening approaches that need to be complemented across. And there are several platforms. For example, in Nepal, we have External Development Partners Group, where we try to generate common consensus and supporting national strategies. And still there are fragmentation observed. And we need to get out of this attribution versus contribution debate here. I think it's understandable, but we need to come out with a better ways of proportionately agreeing on these things. So, and with the recent, this COVID pandemic over the last 1 year plus, now we have seen that a longer term focus on health system is strengthening in order to battle with this pandemic and more. If you look at the monitoring side, how they are, particularly at the subnational level, as I said earlier, where do we lack? Where we need to focus more is the generating more about the resource allocation data and analyzing it, taking into consideration of the service delivery relationship. And also the presentation of the population coverage and health outcome indicators at the national level does not really support all the time the need and approaches that require taking at the local level. So we need to have disaggregated data and quantify within the group variability in terms of really addressing our goal. And I've seen that, it's a longer term process generating disaggregated data, but we should consider focusing on intersectionality, because it's not homogeneous. Unfortunately, we live in a world, there are a lot of differences, disparities that need to be well understood. And often health is defined as a very, very limited scope, but considering the wider determinants of health while allocating resources, as well as the approaches that we have in terms of strengthening our system, need to be prioritized looking at the wider health impact. The issues there are, as I said, defining the health system policy goals and approaches, getting on the same page is always difficult, but it's not impossible. There are consensus being generated at the national and subnational level. We need to work more. Health sector competing with other priorities. Obviously, primarily health need to be seen as a development priority and need to be funded accordingly. There is a quality of care versus quality health system. I think fixing quality of care at the point of delivery does not really support the strengthening the quality health system. So we need to have a greater balance on the service expansion over the quality, maintaining the quality. With the clarity in terms of roles and human resources, as well as very important that we make several decisions, particularly during this pandemic period, but taking evidence into account to inform our policy decisions is really, really important. And it's a strong call at the national and subnational level to utilize our resources in a better fashion. In summary, what I think is only focusing on the public sector and leaving aside the large private sector, informal providers and community will not really address our approach at the national and subnational level. So we require a holistic system thinking. What works in one place, it doesn't work in other place, I guess. And there are ample experience. So contextualization is very important. How do we do that, taking into account? We need to have a better evidence into account. and HSS model basically that has continued reflection. It is not a one-time go. I mean, we need to have a mechanism where we reflect and review and innovate and consider the local context. So particularly in the subnational context, measuring our goal towards the universal health coverage through strengthening the health systems can be challenging. However, we need to have a smart thinking in place and getting existing data, whatever data available, using that in order to inform our decision process is important. Finally, I mean, these are some areas of focus. I just wanted to put for thought. The holistic system thinking, and we have appropriate tool. We need this adaptation at the local context and take that into practice. And leadership matters, particularly at the national as well as subnational level in terms of implementing these policy commitments and aligning the resources of the development partners as well as the private sector through a harmonized health systems, addressing the coexistence issue there and strengthening the public-private partnership towards more rooting out the cause that addressing the health needs to the policy goal. I mean, these are the experience what we often get at the country level. Thank you very much for listening, and over to you, Kabir.
Thank you, Sushil. And I think you really speak from the perspective of somebody who's seen the national, the subnational, as well as the global. So I think that combination of perspectives is absolutely crucial. And as you've highlighted several tensions, the public perspective, which is the dominant understanding of health systems, very public sector focused versus the pluralistic, which is the reality, and the tension between the community health system and the government health system, the disease orientation versus systems orientation. And also thank you for bringing up the determinants approach, which I think is going to be the next big challenge, especially as we move towards this tension between the health security and UHC agendas, where I think we're going to see more of a focus on reimagining health systems much more broadly. So again, more questions than answers, but I mean, I don't see us moving towards a shared understanding yet, but I think that's also the reality of this complex problem. But maybe Jo Keatinge can shed some light for us, and she's back with us. She solved her internet problems. So Jo, let me hand it over to you. But first, let me introduce you briefly. Jo is a general medical physician with a DTMH from the London School of Hygiene and Tropical Medicine. And since April 2016, she's been working with the UK FCDO as a health advisor, managing health system strengthening and universal health coverage. And previously, Jo's worked for 18 years in Africa in a range of roles, including as a senior pediatrician in Uganda, a senior HIV specialist in Zambia, Malawi, and Mozambique, and as a senior health advisor in other roles in Zimbabwe. Over to you, Jo, for your contribution on strengthening health systems.
But just to say, it is fantastic to see so many friends actually on the call. I've been in this journey on systems with you all. And I'm afraid I don't know if we've got all the answers yet. That's why we're trying to still all get on the same page. But what I'm going to try and do is quickly scoot through how we're trying to take some of this evidence, this listening, in terms of that country level perspective that Sushil's just really clearly outlined, and sort of give you an overview of what's kind of the current direction of our systems approach in the Foreign, Commonwealth and Development Office that was previously started with some of the DFID work. And I know that there are people like Julia Watson on the call who started us on trying to put together a health systems paper. A lot of you have said, where is it? But it's coming still. And this will give you a flavor of how we're trying to use the evidence and the political kind of temperatures and environment to push for more effective spend on global health. So it's not that system strengthening, I don't think, is new to many of us. Although I have to say, I was an HIV and I saw Breda Gahan on the call with the concern years ago But it is a different way of doing business. And FCDO is shifting very much from some of the disease silos that we had to a much more system strengthening approach. But it has taken time and takes time. As Sophie's described, narratives, you know, there can be differences in terms of our understanding. We often set incentives that can do harm. And so taking a kind of view of what's going on at the current time. So we've moved from MDGs to SDGs, we've got C19, and embracing those opportunities, but also making sure that some of our previous goals aren't left behind has been a challenge. But I think that we're clearer from an FCDO point of view of the direction of travel. We really value all the work that's done on the evidence. We know better what works. This point that Sophie raised about these interlinkages is so important. I don't think we've spent enough time on looking at that. I think the context, you know, health system strengthening isn't possible in some countries, particularly the most fragile. And we still have gaps. There's very limited evidence on cost effectiveness on HSS, for instance. And as everybody has continued to say, our metrics are particularly weak. So I think we've tried to sort of synthesize all of that in terms of where we're going from an FCDO side of things. Priority is universal health coverage and obviously health security. And we need a system strengthening approach if we're going to manage to achieve those goals. And I think that's landing really well, particularly with ministers, politicians. I'm not sure they always, you know, I think there's some work to be done in terms of getting them to understand what that means because of the challenges that have been outlined in the previous presentations. So we've got work to do still in this common narrative. And I think part of that is because there's no one size fits all. Systems look different in different countries. We don't have a pill. It would be great, but you know, they're not predictable. And so we need to continue to allow the evidence and try out new things as we move along. I also think we've really missed the point that this is a political as much as a technical issue. You know, we know the president of Kenya put UHC and system strengthening as a high priority. And so we need to look at this differently in terms of getting the messages heard. And then there's the sort of the tension in terms of this is a longer term process, it's not a one-off. And a lot of the aid, as has been brought up by Sushil, is, you know, it is short term. And so it is really difficult to plan for some of that longer term action. Coming back to the fact of what Sophie brought up, optimizing one part of the system isn't sufficient. And I think this is one of the challenges we have, for instance, with some of the global health initiatives. We need to make sure that a lab system strengthening that might be to their comparative advantage to support links with a human resource strategy or a health information system or a financing. And there's not enough cross-working. And so this has been, I think, where some of the tensions and difficulties are in terms of programming. And then, of course, the big multi-sector and multi-stakeholder engagement piece that is so difficult to maintain, have meaningful conversations, and ensure that everybody that you want around the table is there. And particularly, I would say, in times like this when we can't necessarily all meet, although Zoom, in fairness, when it works, has been great. So here are the FCDOs, kind of where we're going. We want to keep flexible, adaptive, but you've heard all of that before. But I think we really are trying to look to see how best to do that. And so I think the unanswered questions that have already been raised in terms of, you know, how can we use the evidence, use some of these process indicators to help us balance being adaptive, because I think the political environment changes so much that we need to be speedier. And we're going to try. We may not get, you know, that's why you're all here to help us and let us know. I think the one thing we can do is really make sure our investments work better together. And I think that was also raised in the last presentation. There's a lot of work, and that involves also political as much as kind of voices being heard throughout the process. And then we've got some core principles that I don't think will be a surprise to anybody. Leave no one behind, rights, ensuring there's real country leadership and not tokenized. And I think this thing about doing no harm is really important, particularly in the COVID era, that we're not in too much of a hurry to get delivered a particular sort of tool, but that we really spend time to work out how to deliver those based on the systems that already are there. So based on the evidence, some of the areas where we feel that we need to do better on are no surprise to you. You know, public health functions are big. We tokenized what we mean there. We've got to do better, and they're as important as maintaining key essential services. But people tend to sit in one camp or the other, and we need to bring together the camps so that we really are working across the board. I think financing, I saw Elaine's on the call, you know, where UK has been very strong supporter of health financing, but there's so much to do, and we need to prioritize based on country context. I don't think we've been particularly good in terms of thinking through the health workforce, and we need to do that better given the different mandates of the different investments, whether it's the global funds, whether it's our bilateral, whether it's domestic resources, and really work out how best to do that. So I think that that's a big area that we need to kind of, and we will be trying to push forward as we support global health. The measuring impact, folks, if you've got the answer, send in those. Because I love, and we've taken seriously Sophie's slides on the process goals, but it's a really difficult area. I know the DAC for how much resources we put to systems, you know, we haven't got that right. And I think that this is very much a learning journey for us. So don't ask me lots of questions, because I will expect you to help me answer them, because we haven't bottomed that out. If we had, you know, a lot of us wouldn't be here trying to work out what's going to make sense for multiple purposes. I do think that the health financing matrix is a good example, but I do worry of whether that can be applied across all the building blocks. And I think this multi-sector approach is becoming a real priority for FCDO as well, particularly those links with climate and you know, the broader social determinants like WASH and nutrition. And we haven't got it right. And I think there's a big political economy around that. And we've not quite got the narrative to bring everybody on the same page in terms of that area. So last slide, what are we going to do? We're going to use our network. How are we going to do this? We'll use our networks and continue to work across government departments, including Department for Health and Social Care. We look to working closely with many of you on the call to help us implement, provide the evidence, be our think tanks, work with us. We're showing some leadership. We're delighted that, you know, the Foreign Secretary has mentioned system strengthening as a really important part of the integrated review, and working with our multilats and global health initiatives. And I think Olga's going to talk through the Global Fund perspective next. And I think that continuing to push those kind of investments to work better is going to be really important. And obviously we will have bilateral, regional and country and central programs. But I continue to want to be friends with the academics and our research and development folks. I know we've got people on the call from our department there. It's critical for us. And we're going to need to, and that's why we need to continue to be adaptive and flexible. So let me leave it there. And that's all I had to say. I hope I haven't gone over. And just fantastic again to be with everybody today. Thanks.
Thank you so much, Jo. And yeah, indeed, you did keep to time, but you also raised a lot of really good points. And I think reminding us that we are sort of with lofty ideals about working beyond the building blocks, but we still have a lot of work to do converging between the building blocks. And that's a reality of many countries, that we have different like financing policies in complete isolation with the workforce policy, and that itself is a massive challenge. And also, thank you for raising the issue of the political realities, and that this is a completely political subject. I think that's something that should come up as one of our conclusions and how we deal with that, but also reminding us about the fact that health system strengthening is not just about local and national health system strengthening, but it's about the global compact and the global health system and how that links to the national health system. So I think there's a genuine opportunity to think beyond, you know, what's out there when we talk about health system strengthening, and really what's here as well from a global perspective. So I think making those links across levels is also potentially going to be crucial, especially as those are key determinants of what happens in countries. So I wish we had more time. I think this conversation actually requires several days, but maybe I'll ask Sophie next time to plan a 3-hour webinar. But now it's my pleasure to hand over to Olga Bornemisza from the Global Fund, and she's going to talk about her reflections on health system strengthening. A quick introduction to Olga. She's a senior advisor on health system strengthening at the Global Fund. And before joining the Global Fund, she worked at the London School of Hygiene and Tropical Medicine for 10 years, where she worked to rebuild post-conflict health systems, including options for health financing and mechanisms to scale up health services for displaced and host populations. And prior to this, work in Kenya, Northern Canada, a very diverse experience. Welcome, and we look forward to your reflections, Olga.
Okay, thank you very much, Kabir, and thanks to Kabir and Sophie for inviting me. So just to preface my short speech, and I will try to keep it short because I'm very aware that time is running and I want to leave time for Natasha to come in. These are just really my own personal reflections on the health system space over the last sort of 20 years. So I'm not sort of giving a formal presentation on behalf of Global Fund, and I'm not really going to talk about Global Fund too much. But I was asked to reflect on a few questions. So what is health system strengthening? What are the multilaterals doing in terms of how we approach it and how we frame it, and then how do we evaluate it? So I'm going to be very brief. It's really impressionistic versus data-driven. So let me start. So when I was asked to do this, I started looking back in old slides, and I found this very old slide from the Toyako Summit. I think it's back in 2008 or something, where someone had listed down all the things that were going on. And I won't go through this in any detail, but just to say that there has been a lot of work done in the last 20 years on health system strengthening and what it means. There's been lots of reports, starting with the WHO World Health Report back in 2000. Through all the reports, there was sort of a very a time in between 2007 and 2011, I think, when there was a lot of work done on a lot of the different frameworks. So we had WHO publish Everybody's Business that really put forward the 6 building blocks. There was the control knobs HSS framework. There was WHO's system thinking for HSS in 2009. At one point, there was a high-level task force on innovative international financing for health systems, and it recommended among its many recommendations, it recommended establishing a health system funding platform to try to work on this issue of health systems and the fact that we weren't harmonizing very well around it. And I'm going to talk about more about that in the next slide. Cube around this time from in 2010, and there was also the M&E framework that Sophie talked about for HSS. And then, of course, a lot more things happened in between 2010 and 2021. So I am somewhat, I don't know, I'm not surprised, but I do wonder what it is that perhaps that we're not doing right, given how much work there has been on for the last 20 years. And what is it that we differently going forward to try to make some progress and get a bit more traction, given all the work that was done. Again, just some reflections from my side. A little story that I wanted to tell you was about this health systems funding platform that ran between 2009 and 2012, and I worked on that when it started through to 2012. And I wanted to raise this because it's a very interesting example of an effort, a very structured effort to try to get harmonization between some of the big agencies around health system strengthening. So as I mentioned, it was really what came out of the recommendation from the high-level task force in 2009, and it was an attempt to harmonize the funding and our efforts around health system strengthening between Global Fund, Gavi, World Bank, and WHO. We did make some progress, but then the whole thing kind of collapsed because there was leadership changes at Global Fund, Gavi, and the World Bank. And I think most importantly, the Global Fund's Round 11 was canceled at the time, and Global Fund went through a big shift and moved to a different funding model. So unfortunately, the successes that we had were mostly not brought to fruition. But just to highlight three things that we were working on, the first was that we developed a joint funding request between Gavi and the Global Fund. And you can see in the diagram on the right-hand side what that entailed. And we had it all ready to pilot for round 11, but very unfortunately, we didn't get to test it. But initial feedback from countries was they thought this was the best thing since sliced bread. They thought this is excellent because otherwise it's so fragmented when they make their requests for health systems funding. And we were going to align it with the World Bank as well. We also did some work on financial management and financial systems. So can we do joint audits? Could we do other things jointly financially? And we also worked on M&E framework. So those are the three areas where we got some traction and were really able to move forward. But I think the work overall was much more difficult than we originally envisioned when we went into this in 2009. And I think it's mostly due to the different mandates of the different agencies and the very different bureaucracies that we have. So harmonization in general around health systems strengthening is not that easy. And maybe I'm answering my own question that I put in the first slide. Why are we still talking about this? Okay, so you saw this slide from Sophie about the WHO building blocks, and I think they still remain very relevant today. On the left, you can see what the building blocks are. On the right, you can see the overall goals and outcomes. And I think over time, we have paid more attention perhaps to the right-hand side. This is the way that we're going, and less attention to the left-hand side. But when I say that, actually, I'm not so convinced, because actually the way that we're all organized is still around the health systems building blocks. And I'll show that in the next couple of slides. But just before I go on to that, I also wanted to pick up, and I see this is coming out in the chat quite clearly as well, that there's been some recent work on some recent topics. And I've listed 4 of them here about how to incorporate these new topics or this new thinking into existing HSS frameworks. And so one is the role of communities, and I just put a picture of a recent paper on that, where they do some thinking about how to build this in to the HSS building blocks framework. There's some work going on at WHO around cross-programmatic efficiency and how to build up some of the efficiencies between different parts of the health sector and also between different parts of the vertical programs. There has been work recently by WHO on the essential public health functions, and that seems to be getting some traction. And then finally, and I think because of COVID, there's been a lot of thinking about health security and what do we need to do to address health security at the same time of health system strengthening. So all of these topics have been added into frameworks in different ways, and I'm just flashing up this particular slide. It's one that I saw recently from WHO, where you can see they've added universal health coverage, health security, the different building blocks, common goods for health, and you sort of see how the frameworks are evolving. And I think it's good, but it also leads to an added layer of complexity to try to unpack all of this within these frameworks. So I think perhaps that's why we're also still having these discussions. Okay, so in terms of the building blocks, I said earlier that I actually think they're quite influential still to this day, and I wanted to just show you two examples. So the Global Fund, of course, does have some health systems funding, and it's very much organized around the different building blocks. And in fact, the whole way, parts of the Global Fund are organized are around the health systems building blocks. So we have a lab team, we have a supply chain team, we have an HMIS team, et cetera, et cetera. And there's other organizations, and I'm actually thinking of WHO, that are kind of structured in the same way, that we are structured, many of the organizations, around the building blocks. We also tend to fund health systems using the building blocks as the basis. Not all organizations, but some, and definitely the Global Fund. And this is just an example. And you can see in the purple, like from health management, information systems, human resources for health, health product management, et cetera, et cetera, et cetera. So I think one of the things that we're sort of reflecting upon after having done this for, sort of 15 years is, what is the implications of this sort of more building block approach have on the systems thinking that we're really trying to do going forward? And sort of Sophie mentioned this in her presentation. How do we move towards more strengthening and do less sort of support and gap filling? And what is it that we need to rethink in order to be able to do that? And I think it's not an easy thing to do. And how do we focus more on the right-hand side of the diagram of doing more on health outcomes in UHC? Okay, so two more slides. So in terms of harmonization around the health systems strengthening, I think we've tried to do it in different ways. I think the agencies continue to approach HSS, but in many different ways, and this results in improved coverage, but also leads to some fragmentation. I think there's been some recent efforts to harmonize, sort of building on some of the work that we did on the health systems funding platform through the WHO-led global action plan. So we have the accelerators on sustainable health financing and PHC, but the challenges that we had in the past still remain with the different mandates, funding programs, and bureaucracies. COVID has also given us an opportunity through ACTA to try to harmonize a little bit more. And I think there have been a lot of harmonization efforts around the different building blocks and how we're working there. And I think those have been actually quite fruitful. And then I think there's this sort of plethora of investment cases that are coming up, and those give another way to harmonize. And so just two examples, there's the GFF RMNCH investment cases that happen at country level. And then I saw recently a PHC investment case, which was really aimed at the 4Gs, so the Global Fund, Gavi, GFF, and the World Bank group, about saying, well, if you focus and you fund these 5 things around primary health care, then you will be able to make progress on health systems. Mostly they're quite topic specific. So I think we need to continue to work to go forward, but there's still quite a way to go. And I see Kabir, you're on there, but let me just finish. This is my last slide. Just a few points on evaluation, because I know Natasha is going to talk about this and she's almost out of time. So I think we've spent a lot of time focusing on evaluating the building blocks and the projects that come with the building blocks, and less focus on outcomes and impact at the country level. And you can see in this little diagram that I have on the right that almost 50% of countries have limited capacity for systematic monitoring quality of care. And so you go, well, why is that? Why is it so poor? And I think we have a lot of the tools. So WHO and others have been working really hard, but I think the funding to roll out these tools across the different countries is lacking. And we've generally, as a community, put much more reliance on surveillance systems, which gives you some, but not all of the information that you use. And just a final note that I think the convening platforms in the space around evaluation have been really helpful. So the Health Data Collaborative, PHCPI, and others that bring the different agencies together to try to work on a framework for that. So with that, thanks for giving me the opportunity. Sorry I had to rush, and over to Kabir and Natasha.
Thank you, Olga. And I won't try to summarize all you said. And as you said, we need to squeeze Natasha in the last 15 minutes and get maybe a couple of questions as well, but really a lot of insights there and around the relevance, continuing relevance of the building blocks, but also the challenges created by the silos that have been sort of imposed by them. And some real challenges for us around evaluating in countries when the systems for evaluation are being financed very well. So bigger questions there, of course. Natasha, maybe you'll have some answers for us. Over to you. But before that, a quick introduction. Natasha Palmer has a PhD in health economics from the London School of Hygiene and Tropical Medicine. And she now works with a specialist monitoring and evaluation company called ITAD, based in Brighton in the UK. She's worked for the European Union in Lesotho, and then as a DFID Associate Professional Officer in South Africa. Over to you, Natasha.
Thanks, Kabir, and hi everyone. I feel a bit like someone limbering up at the end of a relay race, so I'm going to try and go as quickly as I can. Also quite tough to follow Olga talking about initiatives in the past which may not have achieved as much as was hoped, but hopefully this one will be different. So I'm going to quickly introduce to you a new initiative, which is the HSS Evaluation Collaborative, which is funded by the Gates Foundation. And I think this draws together many of the strands that have been discussed so far. And hopefully we can talk about a few next steps which could try to bring this fragmented field a bit closer together. We started work on this at the end of 2020. And the stakeholders who were in at the beginning of this initiative were, as well as the Foundation, Gavi, the Global Fund, USAID, the World Bank, and the Global Financing Facility. But as I'll describe, these are not the only stakeholders who we hope to bring in. And in fact, there is a much broader group of people involved in this initiative already. So the initiative is based on the idea of collective impact, which works to bring actors from different organizations together around a common agenda for solving a specific problem. And in the case of this work, the problem is how to better do HSS evaluation. So I thought I would start with a slide which shows all the stakeholders that we hope to bring together in this initiative. As we've seen in the presentations today, there are many different worlds in health system strengthening. So I think that the next slide that's going to come up is going to be a Venn diagram which tries to show the importance of the kind of different worlds in health systems evaluation which we're trying to bring together. So I think the real world where the impact of health system strengthening is hopefully going to be felt has been described most by Sushil today, and is at country level in communities and health facilities. But I think there are other planets orbiting in this atmosphere, and we've also heard from them today. They're the development partners and the academics, and they also have their part to play. And I think the essential idea of this initiative is to try and bring all those different actors together using this collective impact approach. So next slide, please. So where are we starting from? I'll go through this very quickly because I think that people have mentioned most of these already, and apologies in advance. This is a list of problems, but basically we have the lack of consensus around the meaning of the term HSS. And it's not really just language. I think it's that people use the term HSS to mean all manner of things, ranging from the kind of gap filling of renting warehouses up to reforming public finance. Related to that, there's fragmentation between different donors about what their approaches to health system strengthening are, and also what their evaluation needs are. And again, related to that, there's fragmentation between the donors and the information needs of countries, and neither seem to be adequately being met. So evaluations might be performed on projects or inputs rather than on systems development outcomes. And evaluation timeframes are often too short to be able to pick up real change in the system. And finally, the evidence base, as Sophie's already described, is very patchy, and there are islands of evidence on specific programs, but very limited consideration of system-wide effects. Going to routine data, as has been highlighted in some of the presentations already, is difficult. and so on and so forth. Next slide, please. So collective impact, the idea of collective impact is to bring all these different stakeholders together, and it involves quite a structured approach. There is a dedicated backbone support organisation, and in that case it's ITAD. That's the role that we're fulfilling in this. There's a very structured process to reach what's called a common agenda, and then working groups are formed around areas of shared interest, and I'm going to quickly talk about both of those in a minute. The overall picture is to try and move towards a shared measurement system. Whether we will get there in the lifetime of this project, I don't know, but that is the kind of overarching goal of what we're doing. But the principles as well are that there should be continuous communication and mutually reinforcing activities amongst all participants. Next slide, please. So to jump on quickly, our common agenda, which has been formed over the last few months, as I say, we started at the end of last year. We did a range of stakeholder interviews. We convened some prioritization workshops with just the stakeholders who were in at the beginning of the initiative. And we've formed a common agenda which all those agencies feel is important for them to work on. And we're now at the process of trying to invite in other groups and other individuals to work around on these questions. And as you can see, the common agenda consists of three important things. The first is the stakeholder analysis at the top, and then there will be two working groups, one around shared understandings for language, method and outcomes, and one understanding more about how these questions look from a country perspective. I think it's important to stress that we hope these two working groups will interact with each other a lot, that they're not going to remain separate. And also that we've tried to form the working groups based on this idea of the Venn diagram. So within each working group, there should be representatives from country level, from donor organizations, and also from academics, wherever they're coming from. Next slide, please. I'm going to quickly go through each of those work streams. I'm stupidly just looked at the time. So the stakeholder analysis, I think we'll just go through the headlines of this. The idea of this is that we recognize, as has been said already, that this is not just a technical process. It is also, and possibly quite largely, a political process. And so one important piece of work will be to try and understand the different kinds of evidence around HSS impact that different stakeholders want to see, and to try to therefore tailor the work that we do to try to move things forward in that sense. I think let's go to the next slide. So that's the first piece of work. The second piece is working group one, which is going to be really building on the work that Sophie talked about at the beginning, the paper that we did a few years ago. A lot of the issues that came out in Sophie's presentation are going to be taken forward by working group one, I think. So it's looking specifically around what's been done in HSS investment by different agencies, but then really trying to get into this question of, is there a common typology or framework which can be used by different organizations to better understand their own contributions to health system strengthening? And also, very importantly, the question of what outcomes are acceptable or measurable in this field. So that's the first working group. The second one, as I said, is trying to look at, when we can move on a slide, is trying to look at this whole question from country level, because I think what we're really trying to do is close this gap between these different worlds. And so we've proposed 4 questions to the country level group. They'll be meeting on May the 28th, and the first job will be to try and refine these questions. But it's really around the process by which HSS investors engage with health systems in countries, to try and understand more about country level interests and needs for HSS evaluation, to think about potential innovations in methodology, again, harking back to this question of whether routine data is actually the solution to some of this. And finally, to gather information on capacities that could be built to strengthen HSS evaluation. Next slide, please. I think I will leave that for people to read, and hopefully the slides will be shared at the end, because I'm keen to get to the final slide, which is really an invitation. Please join us. This is not a closed shop. My email is going to be on the slide after this, and I'm sure it's on, it's known by the organizer of this webinar. We want to engage as widely as possible. If you're interested in hearing more about this, please get in touch. And in particular, we know that policymakers and people working in countries are very short of time. We know that you can't join working groups. or you can't always join working groups, but we hope to reach out in different ways. So please get in touch as well. And the final slide, I think, has my email on. Thank you, Kabir, back to you.
Thank you, Natasha. So we're at time, unfortunately, and it looks like we won't have time for questions, which is a great pity because I see a number of questions did come through, some very interesting ones. We hope to have a continuation of the consultative process somehow, and I'll ask Sophie if we can open this up maybe to a survey or to some way of inviting more responses. But then there's, of course, the process that Natasha has already alluded to, where she is inviting inputs, and her email, I think the slide set will be circulated, so your email will be on there. So we might get kicked off in a minute, but if we don't, I'll request you to give me 2-3 minutes to sum up. And then I'll hand over to Sophie for the last, for the next steps. So I'm not going to go do a detailed summary because I know all of you will have other meetings and you'll be waiting. So I think what's clear is that, I mean, we couldn't have moved towards an understanding on convergence within a 90-minute frame, but certainly there's some new learning that's come up, and there's a certain amount of convergence that we are seeing in how people are looking at health system strengthening and health systems evaluation. If I were to identify 2 or 3 things that I would say have really stood out for me, one is this emphasis on strengthening evaluation and learning systems in countries. That was referred to by several people, and that of course there's an element of health system strengthening which in itself is unaddressed. The importance of multi-level assessment, so working across the global, the national and the subnational systems, and the emerging importance of the determinants focus with the building blocks, the core health systems issues, and of course intersecting with health security. So then that's going to be the big challenge for us moving forward in terms of how we shift, how we work with that, reimagining a space within health systems, and how we incorporate all those different frameworks. So I think Natasha's working groups that she's setting up are actually trying to address this exact issue of convergence, and whether it will end up being something that takes on many perspectives onto board, or whether it is something that ends up being quite comprehensive and encompassing. That is to be seen, but it certainly seems like a very promising process, and I just echo her that it would be excellent to see lots of different inputs into that, especially from countries and from people working at local and national and subnational levels. Very important further point to make is about political economy, and I think that several people made that point, and that an analysis of political economy needs to be integrated into our understanding of health system strengthening, but also of how we evaluate health system strengthening. So with that very short summary, but thank you again for your patience, thank you for your questions, and thank you to the panelists for those excellent and rich insights. Let me hand over to Sophie for final word on next steps.
Yeah, thank you very much. Yeah, obviously we've packed rather too much into this webinar, and it's a shame we haven't had more time, but I have to say that there have been around 60, 70 questions in the question and answer box, and I've been trying to answer some. I think colleagues are trying to answer them, and I think we can commit to answering them after the session, any ones that haven't been responded to, and putting those on the website. So we will be sharing the presentations if the panelists agree on the Rebuild website, and also recording of the session. And clearly there will need to be future discussions. We've already got some interesting ideas for future webinars from the chat, including how to light the fire of enthusiasm for health system strengthening and kind of sell our messages and what we already know better. So just to say thanks to the panelists, thanks very much to all of the participants for your questions and your thoughts, and obviously this topic we'll need to come back to it, but I think we've made some good progress today, so thank you very much.